we present our experience with transperineal interstitial laser ablation of the prostate. The treatment of benign prostatic obstruction is justified by the related worsening of quality of life, but it is paramount to consider that the natural history of this pathology is progressive and can cause, if untreated, major complications. Thus, the ideal therapy should relieve the complaints of benign prostatic obstruction while interrupting the progressive damage to the urinary tract and reducing the incidence of side effects. From this perspective, the shift from medical therapy to surgery is steep in terms of invasiveness. A lively interest has recently developed on alternative microinvasive options, which do not need general or spinal anesthesia and are potentially feasible in outpatient setting. In addition, a microinvasive approach is intended to have a low risk for complications and do not cause impairment of sexual life. Among these, transperineal interstitial laser ablation was recently proposed for the treatment of benign prostatic obstruction. It is an ultrasound-guided procedure that needs a biplanar transrectal probe and a laser generator. The laser light is conveyed from the source to the tissue through flexible 300 microquartz optical fibers, introduced percutaneously into the prostatic adenoma through 21 gauge needles. The laser light produces an area of coagulative necrosis of ellipsoidal shape that has a longitudinal diameter of 22.5 mm and a transversal diameter of 16 mm. It is localized for 1/3 behind the tip of the fiber and for 2/3 in front of it. Irreversible necrosis of cells occurs as a result of local temperature and exposure time. The 1064 nanometers diode laser has an excellent tissue interaction with low radiation absorption and high tissue penetration. The patient is placed in lithotomy position in conscious sedation with benzodiazepine. A local anesthesia of the perineal skin and of the periprostatic area is performed using 200 mg of lidocaine 2%. The insertion of the 21 gauge needles is under ultrasound control. In order to facilitate the insertion maneuver, the system has a dedicated multi-applicator guiding system for transrectal ultrasound by planar probe with relative biopsy software that displays the guidelines on the screen. It is our habit to flip upside down the transrectal ultrasound images on the screen, but it is not a vital factor to correctly perform the procedure. In higher volume prostates, 2 fibers per prostatic lobe could be employed. The Integrate Echolaser Smart Interface is a useful tool to improve precision and safety during the placement of the needles and the laser fibers. A stopper device locks the needle in the chosen position. One optical fiber per needle is placed. In order to avoid injuries, the laser fiber should be kept at a safety distance of at least 8 mm from the urethral lumen, and its tip must be 15 mm distant from the bladder neck. When the optical fibers are safely placed, we can aggregate energy. The starting power setting is usually 4.5 watts. After a few minutes, we can reduce it to 3.5 watts. Usually, 1800 joules per fiber are delivered. If the prostate has a large median lobe, we can place a needle inside it and ablate it separately. In case of larger glands with a longer anteroposterior diameter, the pullback of the needles allows the ablation of the distal half of the adenoma. Finally, we can perform a contrast-enhanced transrectal ultrasound to directly visualize the necrotic area, which appears as an anechogenic area. From September 2018 to March 2019, 21 patients with a median age of 62 years and a long history of moderate to severe lower urinary tract symptoms underwent TPLA at our department. The median prostate volume was 40 milliliters. Mean total operative time was 36 minutes. All patients were discharged on the first post-operative day and the catheter was removed after a mean time of 8.7 days. A significant improvement in Qmax and IPSS was already shown after 1 month. Such improvement was confirmed after 3 and 6 months. Ejaculation was preserved in all men who had resumed sexual activity. Our conclusions are that TPLA is a technique characterized by efficiency in symptoms relief and urodynamic parameters improvement with rapid onset and durable effect. Short operative time and no need for general or spinal anesthesia, making it potentially feasible in an outpatient setting. Low risk of side effects. Preservation or even improvement of ejaculatory function.